honored to have the Deputy CEO of GAVI here with us. And I have to say that before joining GAVI, Dr. Gupta was Secretary with the Indian Ministry for Health and Welfare, and in this function, she was what was mentioned just right now, the link to the healthcare system of a very, very big country. So I think, in addition to all of the things Dr. Gupta has done in India, she was also involved in polio eradication. She is a very clear advocate for maternal and child health, and in all these different functions, I think she brings them into GAVI now and is a great, great help for GAVI. And we are honored to have you. May I ask you, Dr. Gupta, up to the podium. Thank you for joining us.
Good afternoon, everybody, and thank you for inviting me to make this presentation on how GAVI is helping expand access to life-saving vaccines. And clearly my job has been rendered easy by Svetlana, and she made a wonderful presentation and has already laid the ground for what I want to share with you. So let me try and add to what she has presented. We all know that vaccines save lives. However, prior to the birth of GAVI in 2000, the world was highly unequal in terms of access to life-saving vaccines. 12 million children were dying annually, largely because of preventable causes. More than 25% of child deaths were because of vaccine preventable diseases, and it was unfortunate that poor countries did not have access to vaccines that had been already introduced in rich countries, despite the fact that it was children in those poor countries who required the protection of these vaccines the most. And therefore you see here a famous quote by Dr. Nelson Mandela, who was also the first chair of GAVI and a driving force, behind GAVI's introductory work, where he said that life or death for a young child too often depends on whether he's born in a country where vaccines are available or not. So since that time, we have come a long way, and you see the impact of large-scale implementation of vaccines in 73 countries, the lowest income countries that GAVI started to support in 2000. The child mortality has declined by 43%, but what is most striking is the fact that child mortality because of vaccine preventable diseases has actually declined at a much, much steeper rate, 60%. And that's phenomenal, and that's a tribute to the power of vaccine implementation at scale. So what is it that the Alliance has achieved so far in the last 17 years of its existence and work? We have been able to support countries in additionally immunizing 700 million children, saving 10 million lives, and also helped unlock economic benefits to the tune of $150 billion US. Svetlana presented how every $1 invested in immunization, gives you a return in terms of, productivity gains up to $16. But actually, if you look at the broader economic gains, then this figure jumps to $44. So really huge return on investment. And GAVI also has a very unique model where right from the beginning we have tried to partner with countries in a very responsible manner, where countries also co-finance vaccines and take ownership of these programs. And as their gross national income starts to rise, their contribution goes up, and finally the transition out of GAVI support. This is something which is so unique in global development space, and by 2020 we would see 20 countries out of 73 transitioning out of GAVI support and fully sustaining and self-financing their programs. We started in 2000 with a small portfolio of vaccines, which actually protected children and adults against 6 diseases. But now our portfolio has progressively increased to offer protection against 18 diseases. I would want to emphasize that though children receive these vaccines in most cases, in case of HPV, it is really adults and girls. However, the protection that is offered by vaccines would often extend beyond childhood. So it's not just child mortality that is impacted by uptake of vaccines, but it is also health of general population during their life course that benefits from vaccines. If you look at the comparison between GAVI-supported countries, which we typically call low-income countries, and high-income countries that are not supported by GAVI, you can see the dramatic trajectory that GAVI has been able to ignite across countries that we support. In case of HIP vaccine, you see that there has been a tremendous increase with coverage now standing at 80%, whereas the rest of the world is really 60%. And that is the point that Svetlana was making, that a lot of middle-income countries that are not supported by GAVI have started to lag behind on introduction of vaccines. On pneumococcal, we are very innovative mechanism of advanced market commitment actually incentivize vaccine manufacturers to develop pneumococcal vaccines suited to the requirements of developing countries. And you can see that pneumococcal coverage in GAVI countries is almost at par with non-GAVI countries, and we will soon overtake the rest of the world. On rotavirus, it is already higher in GAVI countries, but as I said, vaccines are being introduced in GAVI support countries every day actually, and every month. So this is an ongoing journey, and we are very, very optimistic that very soon you would see further improvement in coverage of new vaccines that nobody could expect will become available in these countries because they were just so expensive to begin with. Now, as Svetlana mentioned, it is really the never GAVI eligible middle-income countries that have started to suffer from certain vulnerabilities, and they are lagging behind on key vaccine introductions because the kind of prices that GAVI has been able to secure for vaccines are incredibly low. So, for example, for HPV, the vaccine price for GAVI is $4.50 per dose, as against about $120 in US public market. For pentavalent, it is a few cents. So the market shaping work that has been done collectively by the Alliance has really been phenomenal, and that has happened because of the ability of the Alliance to pull together demand from 73 countries that account for 60% of the global birth cohort, and actively incentivize vaccine manufacturers backed by predictable financing that has been put behind vaccines by donors. But I think in part it is also triggered by a series of innovations that GAVI embarked on, including IFIN, the International Immunization Facility, which leveraged successfully capital markets to raise $6.5 billion on the strength of long-term pledges made by donors, 15 to 20-year pledges, which really meant that pending, all that inflow of money in one go from donors, the vaccine bonds brought in money on an ongoing basis that helped the Alliance to fast forward impact and front load investments without difficulty. Our very unique market shaping model has, as I said, shown some very dramatic results. You can see that when we started, we had much fewer vaccines. As I said, we protected against 6 diseases, 50 million doses we were procuring. Now our procurement has gone up to more than 700 doses per year. As a result of the pooling that we have done and the incentives that we have created, we have been also able to make the market much more competitive. And you see that the number of suppliers to begin with was only 5, which has now expanded to 17 vaccine manufacturers and suppliers. And a lot of them really are in emerging countries and have made it a throbbing marketplace which is healthy and very competitive. And that is what has helped ensure that we continue to drive prices down, but we also pay attention to vaccine security so that there is uninterrupted supply of vaccines. We have seen some new risks emerging on this front, particularly with HPV, where now demand outstrips supply. And though we had a huge goal on HPV vaccine, we wanted to reach close to 40 million girls, and we were able to work with countries to mobilize demand for HPV, which is important for adolescent girls and women health, because now we lose about 266,000 women every year to cervical cancer-related deaths, and the number is set to increase. More than 90% of these deaths are in developing countries, yet we have really hit constraint in terms of supply, and that's worrisome. But there are some learnings and lessons there that the Alliance is collectively looking at to see and understand how we try and avoid these bumps going forward. You can also see here that GAVI's unique model of country ownership and co-financing actually has led to higher allocation of domestic resources for immunization. Today, the whole global community is talking about the need for political leadership, commitment, and Svetlana touched on that, and really the need for governments to put their own money on the table. And here you can see that GAVI has actually succeeded in doing that. So in the beginning, we started with very small amount. I wasn't there at GAVI, but I'm told that that was the time when a lot of people believed that countries would never be able to co-finance vaccines. And yet you see now how countries have increasingly taken responsibility for putting on the table their own share and actually increasing it as the GNI goes up, and to a phenomenal amount of 436 million last year. It's almost 50% of this spend that GAVI made on procuring vaccines last year. We also believe, as Svetlana said, that immunization paves the way for universal health coverage. You can see here, Svetlana gave you a global view. This is a view of coverage in GAVI supported countries, and here you can see that the mean coverage of Penta 3 in GAVI supported countries is 87%, and really the mean coverage for all other health interventions, essential health interventions at primary healthcare level, where global community has invested substantially, you see a lot of gap. They're largely less than 50%, with the exception of distribution of bed nets, which is about 60%. So really, immunization can be a true pathfinder and a stepping stone to universal health coverage. We also see that the immunization rates have substantially improved in low-income countries. This is again GAVI supported countries, where you see that we have moved from immunizing 40 million children to 65 million children in 2017. But at the same time, we have also been able to reduce the number of under-immunized by 50%. So when we started out, 30 million children were not receiving their basic vaccination in these countries, and today that number has been halved. And this is despite the fact that population rates in GAVI supported countries have been quite high because of high fertility rates. In fact, in Africa, there has been 40% increase in target population during this last 17 years. We still have a challenge before us, as Svetlana said. We are still missing, she said 19.9 million children globally. Out of that, 16 million children actually are in GAVI supported countries. And she already presented this urban slums. We see a lot of concentration and clustering of unimmunized and immunized children because of large-scale migration from rural areas into cities. Already the population in urban areas is touching 4 billion, is set to increase further. A lot of people who are migrating into cities are unrecognized, unregistered, living in unplanned areas with virtually no facilities at all. So here is a picture that shows you the insanitary conditions in which these populations are living, and they are therefore prone to all kinds of diseases, including vaccine-preventable diseases such as cholera and measles, and which can be highly infectious. So this is an emerging challenge. In the past, urban slums or urban poor have never received due attention, and this is where Alliance is now trying to design new strategies, staying cognizant of the fact that these contexts are going to vary from country to country, and as Svetlana also said, at the subnational level we see a lot of variation, and therefore our strategies need to be adapted to the local context. Remote communities, nomadic populations have always been a challenge. They still are a challenge. The cost of reaching them are of course high. There are difficulties. There are barriers such as lack of health workforce and just lack of physical infrastructure. I do think this is a reminder of the fact that communities that are missing out on immunization actually are communities that are suffering from a much broader developmental challenge, because these really are communities that are deprived of all kinds of basic rights and care, including education, health, sanitation, nutrition. So conflict settings, the number of people and countries suffering from conflict is constantly going up. We now have close to 65 million people who are on the move, who have been displaced. 40% of underimmunized children live in conflict settings, and that is where we find it extremely challenging to even maintain progress. So if you take Yemen, Syria, I think just making sure that the gains that we have already made in some of these countries, are maintained is indeed a formidable challenge, and that's where the Alliance is actually working towards integrated approaches to make sure that every health contact that we are able to make with those populations is maximized. One good news is that vaccination is found to be the most equitably distributed health service across 12 quintiles. This is based on a very recent evaluation that was done of all maternal child health interventions from 1990 to 2016, because the differential between the highest 12 quintile and the lowest 12 quintile is 28%. So to my mind, it is not small, but it is of course smaller compared to several other health services. For example, access to pneumonia treatment has a differential of 60%. So while we celebrate success, on immunization front, we are also acutely aware of the task ahead of us, of really reaching every child that we are missing out today, because reaching every child for us is not just an issue of social and distributive justice, but it is also a smart thing to do, because wherever we have clusters of unvaccinated children, there is a heightened risk of outbreaks. And for diseases that have epidemic potential, we have seen economies can be ripped apart if they are not contained in time. Another good news is that immunization is the most gender equal health intervention. At the global level, boys and girls have equal access to immunization. GAVI has very vigorously followed up on sex disaggregated coverage rates, though we were criticized in the beginning for overburdening countries with data needs. But I think having this assurance that at the aggregate level we see no major difference is indeed extremely reassuring. But this is not to say that every community or every country has gender parity in terms of access to immunization. We still have some countries and some communities within those countries where we still find a difference between boys and girls in terms of access to vaccines. However, we are now increasingly getting more focused on making sure that we identify and address gender-related barriers that prevent mothers who, as Svetlana said, are the primary caregivers in most GAVI countries, to enable them to bring both boys and girls for immunization. This is a picture that I just brought from my recent trip to India, where we are now forging a new partnership with SEVA. SEVA is a self-employed women association with 1.9 million women. They are self-employed, they are informal workers, they are unionized into trade cooperatives, brimming with confidence, energy, extremely aspirational for the next generation, and to ensure that their children and their grandchildren receive the protection that they couldn't receive themselves. And we see this as a huge opportunity. So from GAVI's standpoint, as we move into our next strategy, it is not just gender lens or gender centric approaches. It is actually going to be a strategy that is going to leverage gender, because we want to see women not just as beneficiaries of services, but as very potent change agents. And really, how do we exploit the natural instinct of a mother or a grandmother to bring her child for immunization? And how do we harness the potential and strength of some of these large women networks in order to bring more children into our immunization fold? We have also realized, based on our recent work with several countries around gender lens, that small things can make a big difference. If we are adequately sensitized to looking at gender-related barriers. For example, in Dakar, in Senegal, just changing the timing of immunization sessions to late evening made a lot of difference. Because if you have your immunization session at 11 o'clock in the morning, poor women who are out, working, will not be able to bring their children, because for them, a daily wage is more important than getting the child immunized. And they're not in a position to forego their daily wage. So a lot of these issues, what should be the location of the immunization session? Can we actually hold an immunization session in a place which is more convenient for women to bring their children to? Can it be in a marketplace or a church or some other place which women can easily access, understanding that a lot of women would have very low agency, as Svetlana said. So really a new thinking, and where we are challenging ourselves to look at the whole service delivery design from the perspective of women, and at the same time adopting some new marketing techniques to get fathers into the conversation. So the next strategic period is going to be very critical for us. We are already quite clear that equity is going to be the organizing principle for our strategy in this next period. So really, the missed child, who resides in communities that actually are zero dose, who are receiving no services, is going to be a central priority, and to that we are adding the gender level. One major shift that we are going to make in this new strategy is to really help countries prioritize their vaccine portfolio. In the past, I think what we haven't done actually as an alliance is to have this conversation with countries about their disease burden, about the maturity of their health systems, about sustainable financing, and really prioritize, because a lot of these countries do not have the strength or maturity or finance to do everything at the same time. So I think going forward, this is a big shift that is going to happen. In addition to financial sustainability, we are going to look at programmatic sustainability, really challenging ourselves about some of the programmatic strategies we have. What should be the balance between routine immunization strengthening and campaigns, for example? Resorting to campaigns where Svetlana presented the whole data on measles, we see a resurgence in measles, despite the fact that countries are doing campaigns every 2 to 3 years. So I think really revisiting some of these problematic approaches and moving in the direction of having strategies which are more cost efficient and sustainable is really going to be a new aspiration. So I wanted to conclude by saying that, of course, we celebrate success all the time, and we should, but we are determined not to rest on our laurels or become complacent in this long journey. Thank you so much.